So hello and welcome to another episode of Grief Unedited. This is a space where we have real, honest and raw conversations about grief and loss. So I'm your host, Karen Lafferty, and I'm an accredited counsellor specialising in grief, and I've worked with people for over a decade now to help them navigate their journey through loss. If you want to connect with me, I'm on Facebook and Instagram. Both of those are at Continuum Counselling. Or you can also find me on my website, which is www.continuumcounselling.com. Now, I always say that this podcast is purely for educational purposes, and just to be really clear, that the views expressed within it are purely my own and they don't represent that of any third parties that I work alongside or on behalf of. And lastly, a bit of a content warning, and I think this is going to stand more so than in some of our other episodes today, because the conversations that we have are unedited, they are very raw, and today we're going to be talking about death and the end of somebody's life. So if for any reason this episode feels tricky for you, if you're finding it difficult as you're listening along, that's okay. Please feel free to step away if you want to. It will be here if you want to come back and join back in at some point in the future. Now, today's episode is with a returning guest, which is always very exciting when somebody wants to come back and talk to me twice. So today I have got lovely Dr Suzy Peach with me, and Suzy, I'll let you introduce yourself in a wee second to tell us who you are, but you've got a real passion around palliative care, and I think today's episode is probably going to be quite raw, but I think it's such a valuable conversation because the reason I've asked you to talk on this is that I find often when I'm working with people who have gone through the experience of having a loved one die, it's often that journey of those final days and weeks that can become quite traumatic if people don't have accurate information about what death really does look like and how it might manifest for people. So we're going to really dive into this today in our conversation about what happens, what does death actually look like. So yes, introduce yourself, Suzy. Tell us a wee bit about yourself before we get into the heavy stuff.
Fab, okay, keep this bit light. So I am Dr Suzy Peach and I am a GP. I've always had a special interest in paediatric medicine and in palliative care. I don't really know why that is. I think it is because we are our most real and vulnerable as children, but also at the end stages of life. It kind of strips away the messy bit in between, doesn't it? And crystallizes who we are as humans, what we want from life, that kind of thing. I think as well, I should have mentioned this in my last episode with you, but my interest in palliative care started really young. So when I was at high school, I realised I kind of changed my mind a lot about what I wanted to do with my life, and I didn't really ever think that I could be a doctor. I didn't think that was possible. But as time went on, it was suggested it might be possible. And someone said, well, if you're going to do that, you have to do some work experience. So I worked in a local care home, a long stay care home. So people were there for a long time. So there wasn't a lot of dying going on. But I also volunteered for nearly 3 years at a local hospice every Thursday for 2 hours after school.
Gosh.
So I started that when I was 16. And it was a hospice that had the kind of acute dying wards, for want of a better, there will be terminology for that, sorry, I've forgotten. But there was also a kind of longer stay ward as well for people that didn't really have anywhere else to go. And you had the experience of both. And it was literally just feeding people, helping clean them, sitting with them, chatting with them, holding hands, whatever it was that brought them comfort, reading a book. And I really believe that that is where this kind of interest started with me, because at a very, very young age, I was exposed to dying. And I was there for some deaths. And I still remember the very first death that I saw in the hospice to this day. And I still think about it quite often, actually. And it wasn't traumatic. It really was lovely. And it wasn't at all what I expected it to be. And I think as a medical student and then as a doctor, it's always made me comfortable to be around people that are dying. And you know, if we just found out someone was imminently in their last days of life and it was happening quickly, I would want to be the one who would go and be with that person, be with the family, because I know that that's a particular skill of mine and an interest, and I want to do it well. So Yeah, that's what I wanted to tell you about. Is they actually put me through bereavement counselling training, but
That's
it's like not proper counselling, but like a kind of intro course as a 17-year-old. Remember sitting in this room with a bunch of other people and thinking, I am far too young for this.
Interestingly, I'm confident that same hospice was where I first did my very first ever bereavement specific course.
Yeah, probably the same one.
Yeah.
Yeah, because Karen and I actually we connected through LinkedIn totally professionally. One, I didn't know you were Scottish. Two, we found out we went to the same town. Then we realised we actually went to the same high school, and you were in the same year as my brother,
No,
which is just small
wild.
world. It's very bizarre.
It was
Anyway,
quite a funny conversation, that kind of like 6 degrees of separation of like, oh, hold on, and then all those wee points of connection. It's like, right, okay.
I know. So yeah, it's something that I think as a side issue from being a GP, I've weaned back my clinical work a lot, which is purely on the heartstrings because I love it and I still do, and I certainly miss my old practice an awful lot. But I've started a business called Peach Wellness Academy with my husband, and who's also a doctor. And we've created a program for teenagers and their parents, and also schools to cover the basics of what your health is to boost health literacy. So we cover topics under conversations with your body, conversations with yourself, and conversations with the world. So under world, we've got a big death and dying section that we're currently planning to release within the next year, where we touch on what dying is, what it can look like, how that can feel, what grief is, and also how different cultures approach it, because that's incredibly different. And basically promote more open and honest conversations around that topic, but also around all the many other topics that we cover. So everything from sexual health to nutrition to mental well-being, resilience, that kind of thing, and give young people real trusted information straight from our big bank of experts, that they really can trust to try and boost their health knowledge before they go off into the big world of social media where they get fed so much misinformation. This will give them a really good grounding and a trusted place to start. So that's my current passion. My third child, fourth if you count the dog. That's very, very needy at the moment because we're kind of gearing up to launch this month. But I just feel young people need something just now, and there's a big lack of resources in the proactive space. There's not a lot. There's a lot out there about particular conditions, and people come in with very specific ideas about what's wrong with them. But there's a real lack of understanding about our bodies and our minds and what we can do to keep ourselves well before things get bad. And certainly with death, if we boost death literacy, as a society, we'll cope better with it when it comes our turn or our family's turn, because it will come. And that's the one thing that we shy away from talking about, but actually we should be more prepared and we should talk about it a lot more in advance.
Yeah, absolutely. And I'm delighted that you've asked me to be involved as one of your experts, because I think I am forever on my soapbox about this, and I hear it so often that, you know, young people don't need to concern themselves with those things. They've got a long time left to live, so they don't need to worry about it. And it's like, we teach, this is my personal soapbox, but I'm like, we spend all this time educating young people about like good sex health and sex education in schools. They might go through their entire life and decide not to engage in any sort of sexual activity, but they're sure as hell going to have to face dying at some point, you know. And it's like, yeah, we don't have grief as part of the curriculum for young people, which just blows my mind. That
me too, it completely does. I mean, there's a lot in our we cover everything that they're supposed to teach in PSE. Emphasis on supposed to. Some schools do it well, some less so, because it's not really measured. But we also surveyed thousands of teenagers, teachers, and medics in various different professions to say, these are the things that we think as generalists. These are the things that I've noticed commonly are coming in that are incorrect, or people lack the knowledge of, or are trending. You know, what are we missing? And we've come up with this huge curriculum where we're covering what the real issues young people are facing now or are likely to face. And we're doing it in a fun way, because they're not going to engage with a boring old course. So we've got lots of video in there, lots of quizzes. We also have and feature lived experience interviews, so interviews with people that have had anything happen to them or anything wrong with them. And that is why I'm not launching with the death and dying module this July, because this is a big module and I really want to do it justice. And I do want to showcase lots of different people's experience with grief and dying, and especially across different cultures. So actually, on that note, if anyone is listening and wants to speak with me about potentially sharing their story to help young people or help other people raise awareness, then do get in touch either through Karen or through our website on Peach Wellness Academy.
What we can certainly do as well is at the end, I'll get you to give your social details just so that people have got them towards the end of the episode.
Yeah.
And we always do show notes as well, so people can get your details from the show notes as well if they want to reach out and get in touch, because it's I think it's such an important topic, and I think to have that breadth of cultural experience as well would be really helpful, because again, I had a brilliant guest, Helena Maria Sean, who's talking about her experience of the death of her baby, and her and I talked a lot about that sense of like everything you read about pregnancy, baby loss, stillbirth is primarily coming from that white centered perspective, and actually, you know, you can really step into somebody's experience of what it's like for them. It just totally shifts that care that can be provided. So yeah, I think it's
It does. It does. And these lived experience interviews, I think they're the bit of the programme that I'm the most proud of so far, because it's the one thing, you know what teenagers are like on a whole, not all of them, but you know better when you're a teenager, don't you? You don't like to hold things, and you can't deny someone's real experience of something, and that's the power in this. We tell it in a really informal way. Everyone we feature, it's in informal settings, and it's their real stories, and that's, yeah, there's strength in that. And in our trials that we've sat with lots of teens now and watched them use it, it's the bit that kind of silences everyone, is watching these videos and making it real. So yeah,
amazing.
I should stop there because I'll talk all day about that, and that's not why I'm here.
We can get you back on for another conversation about that. But yeah, it does sound fantastic, and I know I've seen bits of it in the kind of the first bit of the launch of it, but I'm so excited to see where this goes to, because it feels like it might be something that just keeps growing, because it
will. I've got so many ideas, and at the moment we're so busy, I'm having to just park them. I keep coming up with ideas and I'm like, oh, not yet. Another one. No. And that's the thing about being a generalist, because you've got so many hats to wear. So I could turn this, and you know, if something comes up and teens say, actually, can you do this kind of topic? Of course, yeah, we'll add that in. Not a problem. So yeah, it's exciting.
Amazing. Well, let's dive into today's episode, because I think this is going to be a huge conversation, and I am aware that for people listening, this might feel particularly raw, because we're going to have a really honest conversation about death, dying, what happens in those final days, hours of somebody's life. And help me understand whether my language is appropriate or not, because the way I think about death is that, you know, from the moment we're born, we're ultimately dying, you know, we're working towards the end of life. But at some stage, and sometimes due to ill health and certain conditions, somebody moves from that kind of dying, as in like we're just naturally aging as we would, into active dying, where, you know, the body is starting to shut down. Is that the right language to put to it?
But I don't really know what the official, that's what I would say. Okay. I don't know if that's officially recognised as the correct language to use, but yeah, that makes sense. There comes a point where things accelerate a little bit.
Yeah. And from your experience, because obviously I'm so aware you've been working and seeing this since the age of 15, 16, you know, it's like, wow, it's a lot of death and dying you've probably seen. But yeah, from your take on it and from what you understand through that medical lens as well, Suzy, what is actually happening when somebody is in those very last days, hours of their life?
So everything's starting to slow down. I guess if you think about your body as a machine, all the organs are working in harmony. And if one of them stops working for whatever reason, or really massively reduces how functional it is, the others can follow suit. And that's kind of what happens in dying. You get multi-organs starting to fail. People, it's so different for different people in terms of the speed at which that happens. People will stop. The first thing that generally happens is things slow down, if I was to make it as broad as possible. So people have less energy, they want to sleep more, they don't want to eat and drink very much, they take to their bed. And that stage, in my experience, can cause family a lot of upset. because, you know, you hear things like, well, they need to keep moving, they need to stay active, they need to keep eating. And actually, even at times where you've had really good palliative care planning, because you know this is coming, that still makes it very real. It's tangible things. You can see that they're in their bed. You can see that they've not touched that sandwich and they've not touched that cup of tea or whatever it is. And it goes against your human instincts as a family or a carer or whatever. You just want to feed that person. You want to keep them well. And people seem to struggle with that bit the most, especially if that bit's quite prolonged, which it can be. So someone could be in bed and not eating properly for weeks and weeks and weeks.
Okay.
And you get questions like, well, what's going to happen? Are they definitely dying? And there are times, and you know, it's hard for us. We don't know. You can't always put an exact finger on it. It's obvious when it's very much the end of life. And that stage is quite obviously different from someone who's functional and walking around and living their life in however other way they were before. But how long that goes on for is hard to determine. Obviously, we know that someone can't drink. You know, you have to be having some fluids for a couple of days or you will pass away because you'll become dehydrated. But generally what's happening in the body at that stage is the organs are slowly starting to shut down.
I think that's so helpful, because I often find that when somebody's in that space of preparing for somebody dying and then the death occurs, I still find that there can be an element of surprise or shock, and that catches people by surprise. Like, why am I surprised? I knew this was happening. But I think that perspective of, they can be in those kind of final stages of life for quite a prolonged period of time. And people going in and they get into that normal of, you know, that's what their day-to-day is looking like in those couple of weeks. Or and you'll
have some days that are slightly better than other days. So I think psychologically that's quite difficult, because we had the doctor in and, you know, they didn't eat for 3 days and now they've sat and eaten a whole bowl of soup and a sandwich. The doctor must be wrong, or that means that they're not dying anymore. And it really can play tricks with you quite often. That's difficult, but I think looking at it over a prolonged period of time is helpful. So if your loved one, if you knew that they had metastatic cancer, for example, that was non-curable, and they were elderly, and you were told that they're not likely to see out the next 6 months. They do 3 months pretty well, up and about to the shops, a bit more fatigued, but then suddenly they're in their bed. But then they have a good day where they're up in the chair. Still look at, over the last week or 2 weeks, is that different from 3 months ago? It is progressing just slowly. It's just not completely linearly. I guess it goes up and down a little bit. And that's difficult because you want clear answers at that time to prepare yourself. And the clear answer, I guess, is things are deteriorating, but slowly. If you want to, I don't like the word deteriorating actually, because I wish I could have withdrawn that, because like you said, dying is a process. Your body doesn't just suddenly switch off like the movies would have you believe. When we always joke between my husband and I, when you watch a movie where someone dies, 99% of the time we just look at each other and we're like, did they consult anyone on that? What is that? It's just so unrealistic. And actually, that is most of our exposure to what death and dying is. So I think that in my mind, that's how I see that stage. And then slowly, as the organs shut down a little bit more, people become more tired, sleep a lot more, eat a lot less, stop eating, stop drinking. And then you're in your kind of final days, hours, minutes at that point. And I guess the main thing that happens is people can become confused, drowsy, sometimes slip in and out of consciousness. And the reason that's happening is because there's not the same level of oxygen getting to the brain as there was before, for various reasons. Your blood pressure's changing, your heart's changing, it's slowing down, it's gearing down to stop, if you think of it that way. And that can be quite distressing. It's not distressing for the individual that's dying, I must say that, because they're not aware. It's distressing for the people around, because the hallucinations can be quite frightening at times. They might be saying something or talking about someone that's been dead for a long time or doesn't exist, or and that's just because the brain is not functioning properly anymore, because it's not having as much oxygen, and that's okay. And there's a lot about when people become unconscious, I've seen people say, you know, what's the point in being around? They don't even know that I'm there.
Mm.
I don't know. I mean, that's widely debated, obviously. I personally believe that, of course, they do. You know, how can you not know that your loved one is there? I want to believe that anyway, whether it's true or not. So I think being with someone when you can, and comforting them and holding their hand, and actually talking, they might, for all we know, be able to hear what you're saying, but just not be able to speak back because they're too drowsy or slipping in and out of consciousness. It doesn't mean that what you're saying isn't important.
Absolutely.
If there's people around a bedside and you're having conversations, sharing stories, sharing jokes between the rest of the family, it creates a nice atmosphere, not only for yourselves to cope with that, but also for the person that's dying, I believe.
Mm.
Sure, there's no scientific evidence to that, but that's what I think. Yeah.
I remember, of course, this was years ago now, but I remember going to a training course that was teaching more the kind of spirituality aspects of death and dying. And one of the things I hadn't really considered, but was just a total light bulb moment for me, is that I guess at the end of, like, the very end of life, when people are in those like final days, hours of life, as a friend or as a family member, there's very little we can do for them. We can't alleviate their suffering in any sort of way. You know, it's like, hopefully that's been well managed by the medics around. But the course that I was on was teaching that idea of like the things that we can do to support somebody. So things like having, you know, nice fragrances around, keeping the environment calm, you know, talking, as you're saying, reminiscing, telling funny stories, playing music that they loved, you know, things like that, that hopefully can just help the person to feel a little bit more at ease in, you know, whatever way they can. And that for me was just, it really shifted my perspective on those final, you know, days and hours, because up until then I had felt like you were just sitting around a bed waiting for somebody to die. And then it's like, no, actually there's lots we can be doing as friends or family members to
Absolutely.
bring
And I
comfort.
think interesting what you said about things medically should be taken care of. Yeah, they should. I mean, dying is not medical.
Mm.
It's a human thing, right? It matters more. Those last parts of your life matter more, that it reflects you as a human
Yeah.
and your dignity as much as possible, and you have the people you love there. And that's why having early conversations about palliation and your wishes for the end of your life should happen early, so that those
Yes.
things are in place, the medical bits are done and dealt with, and nobody's trying to stick needles in and do things that are not necessary at that stage. You know, have those conversations now so that everything's in place, so that at the very end, it is how you and your family want it to be. And that's really, really important. Now, obviously, I've kind of said that that's how the body kind of shuts down in those stages. It's not always peaceful. It's mostly always peaceful, but not always. And people can experience some symptoms, obviously, when they're dying, mainly pain and agitation.
Mm.
And they are things that we have medicines to cope with. And they are things that we prescribe in advance of there being a problem. So we want to know that someone is dying, and we want to know their wishes, and get everything in place in that person's home for should they experience that. Now, they might not, but if they do, the medicine can then be called upon quickly because it's already there. You have an emergency number, you can phone the nurse to administer that. And the point, I know we're not talking too much about this medically today, but I do think it's really, really important that people advocate for those around them. So if a nurse comes in the middle, if your relative is dying at any stage, right, any stage, it's not for you to decide they're imminently dying or they're 3 months away from dying. They're uncomfortable, they're really struggling. You have those just in case medicines already. They've been prescribed, they're in your home. You have a number, you've been told you can phone it. Phone it.
Yeah.
Always phone it. There are district nurses on call 24 hours a day in this country specifically for that reason, and most of their workload overnight is palliative care. They want to know about, we don't want to know the next day that someone's been suffering for 8 hours waiting for the GP practice to open. Phone them, get those medicines in place sooner rather than later. Also, 2 hours later, they become in pain or distressed again, phone again. They're literally in your area on call for that reason. Don't wait it out. It's not worth it. Death, wherever possible, should be comfortable. And that is, in my book, a non-negotiable. You know, there are always medicines that we can turn to. And yes, some of them end up having side effects. They can make you sick, they can make you drowsy. There's also, we can tailor it, we can change them, we can give things to counteract that. So anyone who's experiencing pain, anxiety, people can get a bit kind of worked up, nausea, vomiting, secretions, I'll come back to that in a moment, but secretions, these are all drugs that we preemptively prescribe for. And then there's other unique cases, someone might need something specific, and we can do that there and then. But yeah, advocate for your loved ones, definitely. If this is happening, don't sit on it, don't wait, because they don't need to suffer. And as long as they are as symptom-free as can be, the death should be peaceful. And actually is often just a lot more traumatic for the people watching than it is the person dying.
Yeah.
Bearing in mind that the kind of reduced consciousness level that I spoke about before is one of the first things to happen in the final stages of life. They don't know that a lot of this is going on. You know, they're quite comfortable. Their body's just slowly shutting down. And that's the way that I like to think of it. Secretions, I said I would speak about because, and again, this might be quite traumatic for some people listening, but if you've been around someone dying, it is quite common. So I do think it's worth talking about so that people are aware. You get a lot, our body produces secretions everywhere, but mainly in our mouths and throats. And when someone's consciousness level is decreasing, they're not able to swallow to get rid of that the same way. So the secretions can build up in the throat and the mouth, and the tongue can flop back, and it can cause really noisy, rattly breathing. They call it the death rattle, don't they?
Death rattle. I was just thinking, yeah, I've heard that language before.
Hate it. It's a horrible phrase. I don't know why. It's just not very nice. But the thing I want to say about that, we know that that is not uncomfortable for that person.
Okay, right.
It's really not nice as someone watching it, because you can't ignore that. It's very noisy. It's quite distressing. You've heard of this thing called a death rattle, so they must be just about to die. Not necessarily. This can still go on for a wee while. Again, some of the medicines we can give to help with secretions can really help with that. So, you know, there are things that can be done. It is worth mentioning it because it does happen, and it usually happens really towards the final stage before someone does pass away.
I think that's really useful as a kind of touch point of what people should be paying attention to. And to me, there's a real power in that idea of having conversations early on in somebody's journey to figure out how much medical input or not do they want, you know, what do they feel comfortable with.
A bit of medical input, just know that you have your drugs in place and you have your emergency numbers in place. But then ultimately, what else, where do you want to be? Who's going to be around you? Bearing in mind that, you know, it's hard to care for someone that's dying, and it's not necessarily the job of the family to do that. I mean, in this country, again, we're blessed that we have good nurses and good carers that can step in, and we can arrange urgent care at home in most areas pretty quickly for palliative reasons, because there are things to consider. Although the body slows down, i.e. your gut won't work the same way, you won't produce as much urine, that still could be happening. And if you're slightly reduced conscious levels, you could be losing continence. So you could have bedwetting, you could have feces coming out, and how would you and your family cope with that? Would they cope with that? Would they be able to and also, do you want to? Do you want them to, or do you want to do that or would you rather maintain that mother-daughter relationship or whatever it is and have someone else deal with that?
Yeah.
And that is okay. It doesn't make you less of a relative, or it doesn't mean that you don't care if you do that bit. But do bear it in mind, because it can happen, especially if someone is going for quite a while in that stage that we spoke about. Towards the very end, I think it's worth mentioning, obviously we spoke about the death rattle. I've said that the bowel and the kidneys kind of shut down, and you'll know that because someone will stop producing urine, and that's a big sign that they're going to go. So if there's not been any urine for a while, they're not drinking, they're starting to make, they're unconscious most of the time, they're starting to make noisy breathing noises, then it is likely that they're going to be not with you probably in the next day. I mean, again, this is very difficult. I've seen people in stages where I've come away from house visits and thought, we'll get, when I come in tomorrow, I'll be hearing that they've died. and then they're still with you 3 days later. So it's very difficult. Even when you've seen quite a lot of it, it's very difficult to predict. What we do know though is the other thing that happens is the peripheries start shutting down. So people get very cold. They can get quite pale. They can actually look a bit blue around hands, feet, legs. Legs can get mottled. I don't know if that means anything to you, mottling. It's kind of funny pattern. If you've seen it, you know that is irreversible. Once that's happening, you're on your way out, because that's the blood pressure really coming right down. Your heart is slowing down in preparation to stop. So less output from the heart, oxygen going around the body, less going to the brain. So that person is going to be unconscious now. And the final thing you'll see happen is the breath change, because again, I think media and movies will have it. You just see this. Usually, it's like, and then someone dies, and that's it. And that's completely unrealistic. You have this thing called chain stroke breathing, where there are big pauses between breaths. And sometimes that pause can be a minute or so long.
Wow.
So you may be with your relative and you think, okay, that's them gone now. And then you'll hear a, and it often is quite a loud, gaspy breath, sometimes a bit rattly because of the secretions. And then they'll go for a while again, breathing semi-normally, and then there'll be another big pause. So that can be distressing, but again, not for the person that's going through it.
Yeah.
You watching it, if you don't know to expect that.
Yeah.
So I mean, they're going to go in the next couple of minutes when you see something like that happening, but just be aware that is your kind of final stages.
Do you know, it's interesting. It's just occurred to me there. Well, it literally just occurred to me there that I guess part of the difficulty as a loved one is that there's so much pressure on that final moment. Do you know, there's so much pressure on that being present for them, being with them, accompanying them as they make that transition. Do you know, and it's like, gosh, it literally is just a moment though that goes between life and death.
That's it. They've got the whole life that happened before that.
Yeah.
You know, that's what really people need to focus on, definitely, because there's so much. I mean, you'll see this, I see a fraction of it compared to what you do, but so much guilt around who was there, who was doing the caring, and it can cause real dilemmas and friction within families when someone dies, can't it? And, you know, there's a lot of fingers of blame come out. And
I'm curious if you've got any kind of sway or say on this, but I've noticed, just as you're saying that, I've noticed that there seems to be a trend where either people seem to deliberately wait until their loved ones are out of the room, they're gone, they've went home for the night, and then they pass, or they seem to be able in some instances, it almost feels like they hang on until the person gets there, and there's and it's like, is that a real thing? Is that just coincidence?
I have no idea what they say about it in scientific literature, but how could it not be? I mean, it's almost every experience that I've been involved in that has been the case. Yeah, it's like that final thing, I'm waiting for things to be in order, and then I can go. And I don't know why that is, but yeah, in my experience, I agree. It does seem to happen quite a lot.
It makes me think about like suppose the power of the human mind, in that sense of like somebody feels that there's unfinished business there, then they're waiting out for that person to get from the other side of the world in some cases, or whatever it is. But it does fascinate me slightly often when I'm working with people, I'm either meeting them, just very late on in the person's journey, so very soon before the death or very soon after. And it always fascinates me, that sense of like what's been going on around about the time of death, because often people have got a story of that nature.
Yeah, that's true. And I don't know why. I've no idea why, but yeah, I've seen it many times, which is quite nice, really, isn't it? Yeah, the other side of the coin, don't beat yourself up if you've missed it.
Oh.
That's okay. I mean, you have no control over these things, and it's what kind of relationship you had during your life that really, really matters.
Yeah.
Not just that tiny bit at the end. It's everything else that's gone before it. I had a point, but I've forgotten again. It's my brain.
I was going to ask a bit about whether you have any sense as to what might bring somebody, either the person themselves who's dying or their friends and family or both, but what might bring comfort in those very final days?
I don't think I think because death is about the individual, I don't think there's a one shoe fits all there. I don't at all. I think trying to have that person's personality reflected somehow, you know, play their music that they like, you know, talk about the stuff that you went through together, even if they can't interact back, talk about it between other friends and family around. It doesn't have to just be a serious affair where everyone's sitting staring at someone dying, like you say. Try and make it about that individual. What brings them comfort? What would they like? You know, would they like particular smells, like you said, particular music? You know, and I really don't think there's much more than that. And obviously, you know, medically comfortable. But we've spoken about that before. I think also it might be worthwhile mentioning, Karen, that we're obviously talking about the majority of deaths here and how the majority of people die, and appreciate that that's not always the case, because you can have quite sudden deaths with trauma or cardiac arrest or what have you, and you don't always, that's where something happened. There's a rapid insult on the body, so the heart rapidly stops for whatever reason, and you wouldn't have this prolonged period. This is more, other processes that are happening in the body that cause it to slow shut down in a kind of slower way, I guess. The thing I wonder whether it might be worthwhile talking about, Karen, in preparation for all of this, we have to speak about, as medics with patients, the do not resuscitate form.
Yes. Yeah.
This brings a lot of emotion. In my experience, more than it's worth. It's a bit of paper that ultimately, especially if you're elderly and you've been given a palliative diagnosis, of course you're not going to be resuscitated. I mean, that sounds really harsh, but that again is due to the kind of public's perception of what resuscitation is, not helped by the media, because I can't remember the stats off the top of my head. I looked at it a few months ago, but something like 70+% of cardiac arrests on movies and in TV shows are successful. And it's tiny in real life. And if you are, 25 and you have something happen to your heart and it suddenly stops and you resuscitate successfully, you'll do well, probably. But if you are 80 and you've got metastatic cancer and kidney failure and liver failure as a consequence, and your heart's a bit rigid too, you're not, even if we tried, you're not going to be successfully resuscitated, because the rest of your body has to be really highly functioning for that to work. And that's what people just don't seem to grasp. Signing a do not resuscitate form will happen as part of the palliative care planning, and should happen. And it should happen because it's in the person's best interests. If someone has a terminal condition, you do not want, in the middle of the night, they suddenly deteriorate. Do you want the ambulance crew coming in and, to be quite graphic about it, ripping their clothes open, putting pads on them, doing chest compressions, breaking some ribs if they're doing it properly, because that will happen? It's really quite brutal. It's a really brutal process, and there's a reason that we're supposed to debrief after whenever it happens, because it's traumatic, even for us, even if we don't know the patient. So if that was your family member, that's not what you want. What you want is, let's plan what happens when they slowly deteriorate and how we react and how we keep that person having the best quality of life in the time that they have and as comfortable as possible. And that's what the focus should be on. And we know that, but we still have to have this conversation about the form. And it's so, I still to this day I don't like doing it, because it feels really, and it's amazing. You can have this, you get a really good relationship with a family. The person knows they're dying. They've decided they want to be at home. You've given, everything's prescribed. They've got the morphine ready to go when it's needed, and And then you have to say, I've got this form, can we sign it? And sometimes people are like, oh, what do you mean? No, I'm not signing that. And you think, well, you almost wish we just didn't have to have that conversation. And of course we do legally, but the reason...
Almost though if you could take that decision out of their hands, of like, as the medical professional, you're saying it's not...
You kind of are having that decision. We're having that discussion. We're dancing around it. How do you want to die? Not like that. So, not with people in the room and pads around it. You want to be peaceful. So it's an odd discussion that probably will come up when you're planning for someone dying, and try not to be offended by it. The other thing is, it does not mean that you're not going to give that person any care. So especially if someone's got a condition where they're slowly deteriorating over 6, 12, 18 months, a do not resuscitate form is often discussed, it should be discussed quite early on in that process, because Saturday night, 10 o'clock, you don't know what's going to happen quickly. So again, you don't want someone being resuscitated that's going to cause them more harm than good. So that should be getting discussed early. It doesn't mean, however, if that person gets a urine infection and needs to go into hospital for some antibiotics, that you're not going to do that.
Because you're going to put them away.
It's not an all or nothing. It's literally just when your heart slows down and stops, we'll not restart it again, which is what dying is. And that's why the form has to be signed.
I was just going to share that I remember a family member of mine was quite unwell, and we're having that conversation about whether they would want a DNR put in place. And I remember them saying that for them it felt like they were at a point in their life where actually to be resuscitated, that they didn't know what quality of life they would have on the other side of that. And it's something that's always kind of stayed with me of like, yeah, you're not dishing out DNRs to healthy people that are cutting about in their everyday lives. It's like, this is somebody who's already gravely unwell, and who, if we were to go through that invasive procedure of, trying to restart their heart, the likelihood is, they're going to be profoundly impacted by that on the other side of it. And is that their best interest? Or is it my best interest as the person who loves them and wants them to be around for long?
That's it. I mean, the way of thinking about it is, if you would put that person under general anaesthetic for a major operation and expect them to survive, then they probably don't need a DNR. But if you would not put them through a big operation under an anaesthetic, like a joint or something, then you shouldn't, because they're not going to survive the intensive care period. Because if someone comes back, they may have had a prolonged period of time with not enough oxygen getting to the brain. They might not be able to function properly. They'll be in an intensive care unit with all the various wires going in and out. And it's traumatic, and it's not what people think it is necessarily. So when it comes to terminal illness or something that someone is going to die from, and we know that, it should be a given that form is signed. But it's just to make your listeners aware that is a conversation that will come up, and not to be shocked by it. It's kind in a way to be having that conversation early.
Absolutely. Thank you for this conversation, because for me there's a real power in the education, I think, around the idea of what does death actually look like. You're so right that it is massively like misrepresented when you look at TV and film and all the rest of it. And I'm not medically trained, and it's funny the number of times my husband and I are watching things where I'm just like, yeah, that's wildly inaccurate. That would never look like that, So I can only imagine for you as a GP what that must be like. You're like twitching watching it. So hopefully this conversation...
It usually makes it quite funny, actually. I can cope with the deaths in movies better, because you're like, that's ridiculous.
The rest of us are bawling their eyes out, and you're like,
about it in the back of the cinema.
I hope that our conversation gives people access to accurate information, about what death actually looks like. And I'm going to finish today's episode with a bit of a plea, I suppose, to anybody that's listening along, because it's a real passion piece of mine that we talk about anticipatory care plans. We talk about what we want to happen when we die, but we do that when we're fit and we're healthy and we're well. We don't wait until we've got that diagnosis to suddenly start getting our house in order and, trying to make amends with the things that we've not done yet in life. So if you're listening today and you're hopefully in a space in your world where you're fit and you're healthy and you're well, if you've not yet thought about your funeral, or you've not yet thought about what you would want your care to look like towards the end of your life, talk to your loved ones about it, or write it down in a bit of paper and put it somewhere that people can find it. But capture that information just now while you're off sound mind, you're feeling well in yourself. Because from my experience, that conversation gets harder the more loaded it becomes.
Absolutely.
The minute you've got that diagnosis hanging around, people automatically are in a heightened space of trying to make decisions, and it can become quite fraught sometimes, and there can be disagreements about what should and shouldn't happen. So, if you've not thought about this before, if you've not even considered it, if you're like I used to be and think I don't want to talk about it because I might bring it into my world, it's not what happens with death. By talking about it, we're not going to suddenly bring it to our doorstep. but you hopefully will be organised and prepared, and your loved ones won't be in that position of thinking, oh God, what do they want? Is this the right thing for them? Is it not? So yeah, if you're listening along today and that isn't something you've considered, then please, yeah, give it some thought, see if it's something that you can do something about, because it gives you peace of mind towards the end, but it also really will help your loved ones in the aftermath of your death to think, right, we did what we needed to do there.
Yeah, definitely. I couldn't agree more.
Anyway, I'm going to say a huge thank you, Suzy, for your input and just your wisdom in this, because I think it is such a big topic and such a difficult topic, I think, for people to talk openly and honestly about. So I really, I felt that the honesty and the perspective you can bring to it is going to be so useful for people to hear. And I also get that real passion that you have for good palliative care. And yeah, I'm just still struck by the fact you've had your sleeves rolled up and in this world since the age of 16. So yeah, I think that's quite wonderful.
Well, me too, actually. When I think back now, I'm like, what the hell was I doing? But hey, why not? I mean, you got to, it's real life, and that's what's important. Yeah,
absolutely. So if you found today's episode useful, we always ask that you take a moment to like it, to share it. If you're not already subscribed to the podcast, please do hit the subscribe button, because that means that you would get notified whenever we've got another new episode out. And I'm going to just finish, Suzy, by asking, where do people find you if they do want to connect with you?
Sure. So our website is called peachwellnessacademy.com. I think. But if you Google Peach Wellness Academy, it'll come up. I'm not sure the exact line. We have social media channels available everywhere, because we're trying to reach young people. So we have an Instagram, again, Peach Wellness Academy should come up. We have a Facebook account, we have a TikTok, and I also have a LinkedIn and an X, actually, all of them. So basically any of them, look up Peach Wellness Academy on there, and there will be some contact details through the website, and you can reach us that way if you do want to be involved at all in any of it. Or if you're interested for your own family, of course, then all the details are there for you too.
Amazing. I was also going to give a reminder, if anybody wanted to be part of the Peach Wellness Academy in terms of their lived experience, then
absolutely,
you would be
reach out, definitely. Yeah.
Amazing. Thank you again for today's episode, and that's all for today, folks. So I hope that this episode has been useful for you. Please be gentle with yourself. This has been a heavy topic and something we've really kind of dug into today. So yeah, if you've been listening along, just please be gentle with yourself afterwards.
That's what I was going to say, actually, Karen, because you said this is a difficult thing for people to talk about. It is also a difficult thing for us to talk about. And even coming into today, I was a bit like, oh, how am I going to say this to a wide audience? Because everyone's experience is personal and very different, and these conversations can be very triggering. And that's why I think having them early, knowing what you could expect, can be really, really helpful. But it is difficult for us all to talk about. I reckon the more we talk about it, the easier that becomes.
Yeah, and hopefully the more we talk about it, the more we become confident in the conversations, we become confident in our use of language, we become confident in advocating for ourselves and for our loved ones. So yeah, hopefully the benefits of this conversation will keep rippling out there in the world.
I hope so.
Amazing. Listen, thank you once again, Suzy, and yeah, I'll see you all for the next episode.